So here's lesson A for EMS 280, the cardiac patients course. And in this one, we're going to talk about chest pain and talk about chest pain from causes that are really not cardiac, although we have to always assume so and rule that out. We're going to talk about how to do the appropriate focus history and physical on chest pain patients, and must include a look at both the cardiovascular, respiratory, and GI systems. Talk about 12 leads, lung sounds, temp, cap, how to palpate, when to palpate, some attempt to reproduce the pain, and just the basics of the focused H&P for a chest pain patient. So what can cause a patient to have chest pain and not have it be a cardiac source? Well, it could be a spontaneous pneumothorax. Sometimes these are from a weak lung tissue, either from lung disease or just congenital defect. For some reason, tall, thin, young males are frequently involved with spontaneous pneumo. And to state that more correctly, of all the spontaneous pneumos, a lot of them are in tall, thin, young males. It's not that tall, thin, young males frequently have a spontaneous pneumo, but if you talk to any experienced field provider or ER person, they can give you several examples of spontaneous pneumo, and almost all of them come in that group, tall, thin, young males for some reason. So just keep that in the back of your mind when you're running a call on a guy with some chest pain or maybe a little mild shortness of breath, and he's tall, thin, and young. These people may not really show up as very short of breath. A couple that I have seen have not really appeared to be short of breath. They were nauseated in one case. And you may not be able to clearly hear the absent lung sounds, as opposed to a traumatic pneumo where you've got 2 or 3 lobes down. You just may not be able to fully appreciate the lack of lung sounds. You certainly should listen, but just keep this all in the back of your mind. There's really minimal treatment. It's in the field. It's mostly oxygenation and ventilation. These don't turn into tension pneumos hardly ever. And so spontaneous pneumo is one cause of chest pain that's a non-cardiac situation. It's not a horribly big deal. PE, on the other hand, can be a huge deal. Can be a cause of cardiac arrest. These are typically sudden onset of shortness of breath. If they have pain, they can localize it, as opposed to cardiac pain, which is more general. This is usually, you can point to it with 1 or 2 fingers. It's worse with a deep breath, which means it is pleuritic. Pleuritic pain is worse with inspiration. Again, sudden onset of the shortness of breath and or chest pain. They don't have to have chest pain. They don't have to be short of breath, but typically they will have both. Heart rate's usually up unless there's some medication keeping their heart rate down. They may be acutely hypoxic, or they may not, at least initially. And this is a risk for acute right heart failure. That right ventricle is not used to pushing against high pressure, and now there's a clot in the pulmonary artery that is creating a bunch of back pressure, and it makes it hard for that right ventricle to pump. And so these folks can end up in acute right heart failure from time to time. And the treatment for management for these folks is to maintain their blood volume, maintain their preload. That right ventricle really needs preload, and so we need to maintain it. Pleurisy is just an irritated pleura. You have 2 pleura. Remember the visceral and the parietal. They slide over each other with a little bit of pleural fluid in the middle, and either of them can become inflamed, and then you end up with pain anytime that chest wall moves. Anytime the lungs expand or contract, it's painful. You may be able to hear the pleura having trouble sliding over each other, a friction rub. I don't think a lot of us are real skilled at that, but you may listen and hear a sound that you're not used to that sounds like a rub, and that may be helpful in your differential. Again, usually made a lot worse with a deep breath or a cough. It hurts just to normally breathe, and so a deep breath or a cough would be extremely painful. Pneumonia can also cause some of this sort of tenderness, so you want to, when you're thinking pleurisy, also think, is this possibly pneumonia? And pneumonia patients can end up being septic. So is there a change in the patient's cough? Are they coughing up nasty colored stuff? Or do they have a fever or chills or something like that? Then there can be chest wall pain. Maybe you just have strained intercostal muscles and connective tissue. And so when you take a deep breath, your chest wall moves and that will hurt. And then if your chest is palpated, if it hurts for you to push on your patient's chest, it really tends to make you head in the non-cardiac direction. You should always consider a cardiac cause, but it can just be sore chest muscles. And that's one possible cause. Another thing is called pericarditis. That's an inflamed pericardial sac, usually a viral infection that starts. It can be bacterial as well. The interesting thing about these folks is that their pain tends to either go away or be better when they are leaning forward, in a sitting position, leaning forward, and it's much worse when they're lying down. So that may be diagnostic, at least in the field, as the cause of this person's chest pain. You certainly want to do EKG, but realize that you may get ST elevation in a whole bunch of leads, and it may look to you like it's a massive STEMI, when in fact it is some ST elevation in multiple leads. They usually call this sudden onset, and they usually describe it as sharp, which would be, the sharp would be kind of tending to take you away from cardiac pain. But really this lesson is about non-STEMI, non-MI causes of chest pain, and pericarditis certainly has to be one of them. But we really just need to make sure that we've got them covered and that we're thinking that this could be an acute coronary syndrome. And remember, your 12 lead is what you need in order to look at ST segments. Don't rely on ST segment elevation or depression without a 12 lead. Don't do it in the limb leads. You need that 12 lead in order to get the appropriate definition and sensitivity that you really can't get. It's a diagnostic 12 lead. It's not monitoring quality. Also remember that even with a 12 lead, the lack of ST elevation does not rule out an MI. You can have a non-STEMI, non-ST elevation MI. And so also early on, we may not be seeing actual ST elevation. We may see some depression. And so it may be that you've gotten to this patient before the STEMI is visible on the 12 lead. They're having an MI, but it isn't a STEMI in that we can't see it on the 12 lead. And then the top note there, many patients do not have the standard presentation. So standard presentation is the minority. So the substernal heavy pressure squeezing radiating to the jaw or arm or elbow, that's pretty classic, but there are many more patients who don't have that than who do. And then again, remember that the elderly patient or the female patient or the diabetic patient are less likely to have this standard presentation. They may have just some vague pain or some nausea and vomiting or weakness or fatigue or syncope or something. And so just keep your eyes open, always be thinking cardiac, but get out of the mindset of if it's not chest pain, it's not cardiac, and if it is chest pain, it is cardiac. That's too simplistic for paramedic level stuff. How do you prep for this lab? Remember, there's lots of things that cause chest pain. It could be an MI, with or without ST elevation. It could be a PE. It could be a thoracic aortic aneurysm. But it can also be caused, chest pain can be caused by many other things that aren't particularly life-threatening. They're just uncomfortable. And so that's one of the main points. You want to get a focus, history, and physical going on these people pretty quick. Usually you'll be able to move through the are they coded or not pretty quickly, and because they aren't, and they might, but they aren't when you first encounter them. Work your way quickly into CVO, check that radial pulse, and start adding limb leads and then 12 lead as soon as appropriate. Do your full respiratory assessment as well. Get lung sounds, get some capnography, pulse oximetry, and get a temperature. Remember, pneumonia is one of the things we're wanting to rule out here. Now, a person can have pneumonia and not have a temp. A person can be septic and not have an elevated temp. But it's an excellent and an appropriate thing to include. You need to push on their chest, have them take a deep breath, have them cough, have them lean forward. So move these folks around. It's a history and physical, And so you can ask some history questions while you're doing the physical, and the physical is much more than just a 12 lead. Consider your differentials for chest pain. Could be an MI, could be a PE, could be an aortic aneurysm, could be chest wall pain, could be pneumonia, could be pleurisy, so could be a spontaneous pneumo, could be a whole bunch of things. But look for the things that kill first. Remember, we're searching for lions, tigers, and bears, not zebras. So make sure that you're looking for these things that are a big deal. Only 2 scenarios with this lab. The first one is a young male patient who is healthy, no cardiac risk factors, has a sudden onset of mild dyspnea and some chest pain, and his vitals and history are pretty much unremarkable. So a pretty easy management, but again, keep thinking, 25-year-olds can have heart attacks. 25-year-olds can have PEs. 25-year-olds can have pneumonia. They can have aortic aneurysms. They can have spontaneous pneumos. And so the age of the patient, while it doesn't suggest cardiac and the guy has no cardiac risk factors, just be thorough. Then scenario number 2, you have a person who's a little bit older than the previous patient. I don't think 56 is old, but certainly not 25 anymore. So we have a 56-year-old guy with chest pain, mild dyspnea. He has a few cardiac risk factors. The pain woke him up, or when he woke up, he realized that he had pain. Either way, his vitals and history unremarkable. What you need to do, the full cardiac assessment, you need a 12 lead, the full respiratory assessment, you need lung sounds, you need capnography, you need a temp, you need pulse oximetry, and the full history and physical. Push on his chest, have him lean forward, have him cough, have him take a deep breath, do your history of present illness, your HPI, and when did it start, what's going on, what were you doing, the full good vitals and history. And so that's the key for this lab, is that you get a good full chest pain history and physical, where you're thinking differentials, you're thinking more than one system, you're not being fooled by the age of a patient, and you may jump to a conclusion, and that's fine. You may walk in the door and you say, oh, this is a STEMI, but let's check everything else. A lot of people can guess the answer right off the bat. Your job is to look at everything else that it might be. And so work on that and make sure that you fully do a good history and physical on these patients. So that's 280 Lab A.